organization. It's funded some of my work at critical points in my career, and many, many junior scientists help them to get their career started. So it's a particularly wonderful to be here to really celebrate BPRF and its impact on psychiatry. As Dennis said, research is all about teams, and one thing that Dennis didn't say about teams is that he is a uniquely visionary team builder and inspirer of teams. So it's been a wonderful friendship and collaboration, and I'm really grateful for his mentorship over the years. The work I'm going to be talking about today also is work of teams, a team of investigators at Yale, and particularly Ron Duman, who's done some of the seminal basic neuroscience work on ketamine response, and Chadi Abdullah, Marina Esterlis, Jerry Santacora, who's done a lot of the imaging work that I'm going to talk about, and Angela Cappiello and Rob Berman, who worked with us on the first study way back almost 20 years ago. And of course, everybody's support. And like Dennis, I need to disclose that I have consulted some pharmaceutical companies, and most relevant to the ketamine presentation today, that patent that Yale has a share of, I have a share of the Yale patent, was licensed by Janssen related to the use of ketamine for treatment-resistant depression, intranasal ketamine, and for suicide. So, one of the most remarkable moments in the history of psychiatry was the late 1950s. In that period, if you go from 1949 to 1957, essentially all of the medications that we use to treat major psychiatric disorders, their fundamental mechanisms were discovered and implicated in the treatment of depression. So that by 1957, essentially, there were only tweaks of those mechanisms, such as the introduction of SSRI antidepressants, which are a tweak on the mechanism associated with the tricyclic antidepressants, which were discovered in 1957. So this has been a banner year in psychiatry because we've had the first two medications approved by the FDA, esketamine or Spravato, and another one for postpartum depression called Brexanolone. And so what I'm going to talk about is to follow along the story that you heard this morning from Dr. Charney about how kind of our team came together to identify the antidepressant effects of ketamine. And then I'm going to talk a little bit about some of the brain mechanisms, underlying brain mechanisms that seem to be implicated in how ketamine can work so rapidly and so effectively in so many people with depression. But I think it's useful to take a step back and talk about just how bad depression is. A group like this probably knows firsthand, either from personal experiences, family members, or friends, how bad depression can be. But I find when I talk to groups of people, they often think that being depressed is like having a bad day. And I want to highlight that it's really much different than that. First, it's very common. The reason most of us know someone who's been depressed or have been depressed ourselves is because so many people struggle with depression, particularly if you define it relatively broadly. Secondly, depression is the most disabling medical condition we have. Not AIDS, not cancer, not heart disease, but depression. And that's because so many people who get depression are disabled by it and can't get the kind of treatment they need. Either they can't get access to the treatment, or when they get access, the treatments aren't as effective as they need to be. Lastly, depression is more lethal than we think of. So we know that that the suicide rate is rising, but you might not appreciate that in the last couple of years, as the mortality of many other conditions have dropped, like breast cancer, the mortality of breast cancer has dropped, that things like suicide are now suppressed, more people die of suicide than of breast cancer. And if you have an episode of depression, it has such a profound effect on your entire body, as in Sophia's presentation, Dr. Charney's presentation, and Will's presentation today, that having an episode of depression, particularly if it's not well treated, has a measurable impact on your life expectancy. The sad and troubling part is that the generations of standard antidepressant medications, which we know help so many people, they still are not as effective as we hoped they would be. Too few people respond to their initial antidepressant in the STAR-D trial. It was about 1 in 3. Even with many combinations and many attempts to get people better, the effect of a new medication is too incremental, so that after multiple trials, each of which only increased your improved remission by about 10 to 15%. At the end of the year, 30% of people in the STAR-D trial, which was the largest. They want me to sing into the microphone. I feel like Frank Sinatra. Anyway, so even at the end of a year, 30% of people in that study had not responded. And if you were one of the people who were lucky enough to respond to a regular antidepressant, on average, it took 2 months to get remission. So that's a long time to wait when you're depressed. And in my clinical practice, I feel like I can almost always get somebody better, but we have this terrible problem which we don't address adequately in the field, which is relapse, return of depression in someone who you've gotten better for a period of time. In the STAR-D trial, again, if you fell into the group of treatment-resistant patients, which meant that you went to the 3rd or 4th step, the chances of having a return of your depression over the following years is about 75%. That's very discouraging. So, following up what Dr. Charney presented this morning, it was a whole generation of research that he conducted before he started doing the ketamine work that really laid the conceptual framework that was important for discovering ketamine. And that was that there was good reason to think that serotonin and norepinephrine systems were implicated in the antidepressant actions of antidepressants. That Dennis and George Henninger and Pedro Delgado, others at Yale, found that if you depleted the body of serotonin, it could transiently reverse the effects of SSRI antidepressants. If you depleted the body of norepinephrine, it could transiently reverse the antidepressant effects of norepinephrine targeting antidepressants. And if you took the heroic step of depleting the body of both serotonin and norepinephrine at the same time, you could generally reverse the effects of most antidepressants. And so, but people confused this with the notion that serotonin and depression were actually causing major depression, or disturbances in serotonin and norepinephrine were causing antidepressant. And Dr. Charney led this group of investigators to conduct another set of studies, which found that if you give healthy people, if you deplete serotonin in healthy people, you didn't necessarily cause depression. Or if you depleted the body of norepinephrine and dopamine, you didn't cause depression. And there was even a study where you depleted both serotonin, norepinephrine, and dopamine in healthy people at the same time and still didn't produce depression. And this was kind of like a conceptual crisis. And as I was preparing the talk today, I was reminded of a quote from Ernest Rutherford, who was called the father of nuclear physicists, a Nobel laureate, one of the smartest men who ever lived. And there's a quote of him. He says, "Gentlemen, we've run out of money. It's time to start thinking." And this is what you come to a conceptual crisis, and sometimes that's the most exciting and creative moment out of all the research. And so I used to go up at the end of as Dennis said this morning, I used to go up to his office at the end of the day, and we toss up ideas for research studies and deal with issues that were coming up. Why did I go up to his office? Because his office was much nicer than my office. So it was a good place to go. So we simplified the problem into a very simple idea. And the idea was that almost all of the research on depression at that time believed that the pathology of depression lay in the cells that release norepinephrine or serotonin. These are cells that live in primitive parts of the brain and have a role in tuning the activity of the higher centers of the brain, the higher centers that actually generate and regulate mood, the cortex and the limbic system. We said, well, what if we turn that problem on its head? What if the pathology doesn't lie in the norepinephrine and serotonin systems, but that these are systems that can be recruited to try to treat depression? What if the primary pathology actually lives in the cortex and limbic system cells themselves? What if it lives there? One profound implication of this simple shift in perspective is that it made us think about different neurotransmitter systems in depression. In other words, the cortex and limbic system use glutamate and GABA as their primary signaling mechanisms, not chemicals like serotonin and norepinephrine. So we thought, well, what would be the best way to probe the role of glutamate in depression? And it just so happens that it was sort of like Reese's peanut butter cup commercial. Dennis brought his depression issue, and I put my ketamine, my glutamate, into his depression because I had been working on glutamate psychopharmacology and studying the drug ketamine in relation to the biology of higher cognitive functions and psychosis. And we had found dose-related effects of ketamine. And we had used a dose primarily, as Dr. Charney mentioned earlier, of 0.5 milligrams per kilogram over 40 minutes. This was a dose that had robust cognitive and behavioral effects, but didn't impair people from performing a variety of tasks. When we gave that same dose to people with depression, we got these results, which is this, within hours, some alleviation of depression, and within 24 hours, there were actually some people who said, oh, my depression's all better. And one of the most important things that you should take away from this figure is that the antidepressant effects are not overlapping with and not in any way related to the euphoric effects. There is no persistent euphoria that accounts for the antidepressant effects of ketamine. In fact, all of those effects go away long before the antidepressant effects emerge. So in a way, and I'm going to come back to this later, the antidepressant effects of ketamine are a brain's reaction to having been exposed to ketamine. And it does not produce elevated mood in everybody. It is not a drug that you give to healthy people to improve their moods, because if healthy people get ketamine, mostly what they experience during this window when people with depression are feeling better, most healthy people are feeling hungover. Most healthy people are feeling hungover, like they've had too much to drink the night before. Okay. So I'm going to have someone who's actually gone through it tell you a little bit about what it's like to have ketamine as a treatment.
I've been in treatment pretty consistently since I was in middle school. I had a combination of different styles of therapy as well as different medications, and my functioning was pretty high, but I tended to still really struggle with these feelings of just profound aloneness and despair. And about 3 years ago, I kind of slipped into what I would consider a very severe depression. I'm receiving intravenous ketamine, and the day after I received my first treatment, I felt like myself. But what was strange, it was like immediate. The next day I woke up and I felt I could internalize good things about myself. I could feel positive feelings. I could feel feelings in general. The gratitude I have for this treatment. And so thankful I live in an area where there's such innovation happening. I didn't even know this was possible.
It wasn't intended to be a commercial here, but you get a feeling that this is a remarkably transformative experience for many people. It's not just a lightening of their depression, but in some fundamental way, an alleviation of the suffering that they've had with depression. And it is generally sustained by periodic administration of ketamine, or now S-ketamine, in order to maintain the benefit on a longer-term basis. As Dr. Charney noted, one of the most striking things about the rapid antidepressant effects of ketamine is the ability to reduce suicidal ideation, and the possibility that ketamine may play a role in helping to manage severely depressed people who have not responded to other kinds of treatments and who have prominent present prominent suicide risk. Lastly, as I mentioned, oftentimes in psychiatry you can get somebody better, but only to find that their symptoms return over time. And one of the striking pieces of data from the development of S-ketamine, or Spravato, the Janssen drug, was that people who responded to the combination of a new antidepressant and ketamine were randomized to either stay on ketamine or to stop taking the ketamine. And if they stopped taking their ketamine, over a year they had almost a 58% chance of relapse, whereas if they stayed on the ketamine, that risk was substantially reduced. This is a very low rate of relapse for patients in treatment for treatment-resistant depression. Remember, in the STAR-D study, people who had remitted there had a 75% chance of relapsing over a year. Here, if they stay on a new antidepressant, it was about 60%, and about less than half if they stayed on their ketamine. So this is an exciting time. Ketamine and maybe other drugs that will follow it, like ketamine and S-ketamine and other drugs that may follow it, may produce rapid relief, may have some value for treatment-resistant symptoms of depression and protection against relapse. So how does ketamine work? And I think when Time Magazine did its article about ketamine, they called it the anti-antidepressant. And I think that's really a kind of a neat way to think about how ketamine works in the brain. In order to tell you a little bit about how ketamine works, I want to introduce you to the cerebral cortex. In particular, you can start the movie. In particular, this is a slice of the brain, and you're looking at the glutamate neurons in the brain. And this is from the work of Jeff Lichtman at Harvard University. And if you zoom in close on a glutamate neurons, you'll see these very interesting structures, these blebs sticking out here. These blebs are called dendritic spines, and they are the sites where glutamate cells communicate with each other in the brain. In other words, the inputs attach themselves to the dendritic spines in order to make synaptic connections. Pardon? 2 minutes? Okay. Now I'm going to speak incredibly fast because I have 2 minutes. No, we can get the basic ideas out. So here you see the dendritic spines, like in the pictures that you just saw. Under stress in animals, those dendritic spines are depleted, but rapidly after a single dose of ketamine, those spines grow back and make new synaptic connections in animals. Is that relevant to patients with depression? Well, the first question is, are there reduced synapses, synaptic connections in the brains of people with depression? Now, Irina Esterlis and Sophie Holmes in our collaborative group did a study using a PET tracer that binds to the nerve, a protein in the nerve endings of nerve cells, and showed that in patients with severe depression, and even some with comorbid post-traumatic stress disorder, that there are, in fact, reductions in this PET marker for synaptic density associated with depression. Equally important was that those reductions in synaptic density were associated with poorer communication between areas in the brain involved in the regulation of mood. So what is the relationship between that and the antidepressant effects of ketamine? Here you see a study that actually came from Dr. Charney's group, but it was written by, the analysis was led by someone in our group, Chadi Abdullah. And this is a study showing that there are reductions in cortical communication, or what's called functional connectivity, in patients with treatment-resistant major depression. But 24 hours after a single dose of ketamine, those reductions go away. So in animals, you have deficits in synaptic connectivity that are restored by ketamine. In patients with depression, you have deficits in synaptic density that are associated with impaired functional connectivity, and that impaired functional connectivity is alleviated by a single dose of ketamine. So in summary, what I've shown you is some evidence that ketamine constitutes a kind of fundamentally new way to think about the treatment of depression, particularly treatment-resistant symptoms of depression, given its rapid antidepressant effects and the fact that it's given very intermittently as opposed to a kind of a drug you take daily. I've shown you some evidence that it works through some fundamentally new mechanisms for affecting brain structure and plasticity, and that, although I didn't go into it today, as we unravel the biology about how ketamine works, we're learning new things that might point to other types of treatments for depression as well. So again, this has been a really exciting story to be a part of, a thrill to share from the early days of this work with Dennis Charney, and even more exciting to see it amplified in society. So thank you very much.
You did it, great. Yeah. Yes, sir. I mean, yes, sir. Oh, well.
Rather than looking at it for depression with bipolar and mental illness depression,
right.
Why are you limiting it to just, I don't know, the treatment-resistant one?
Right. So the question is, why has the FDA limited the approval of ketamine to people with treatment-resistant depression? And the answer to that study is that the studies that were conducted by Janssen with Spravato were of patients with treatment-resistant depression, not the other subgroups of depression. However, the academic investigators have, in fact, studied the efficacy of ketamine for other forms of depression, like bipolar depression, and found evidence of efficacy. So Carlos Cerati, in particular, working in Dennis's group at NIMH and then continuing on, has found that it is helpful for bipolar depression. In patients who have bipolar 1 manic depressive illness, there is some concern about stimulating hypomania, so it's recommended that people stay on mood stabilizing medications, but it has been tested in bipolar depression.
Yeah, well, the fellow didn't get a chance. Yeah.
How long has ketamine been around? You said in one of your slides it was originally an anesthetic.
Right.
And at what point did you say why don't we try this old anesthetic and street drug? How did you happen to move to that?
Right. So for us Detroiters, ketamine was discovered in the early 1960s in Ann Arbor, and first tested by Ed Domino, who was an investigator at the University of Michigan and collaborated with the group at Lafayette Clinic in Detroit. But when it was discovered, people had no idea how it affected the brain. It wasn't until 1983 that it was figured out that ketamine blocked a receptor for the transmitter glutamate. And it was not that far after that time, that in around 1989, where I wanted to, once we knew how it worked, where we wanted to employ it as a pharmacologic tool in research. And from 1989, it was only until 1995 where we started to depression. But I think your question raises an important point. We first reported the antidepressant effects of ketamine in 1997 at the Society of Biological Psychiatry meeting. And it didn't get approved as a treatment for depression until 2019, right? So it gives you some idea how long and slow the research process is, and how initial research, this program in a way started out as a psychosis research program around 1990. Right? So 30 years. So research, you have to be in it for the long game, because even when you think you're onto something really big, it can take a really long time to develop into a real treatment.
One more, unfortunately. Yes, sir. Yeah. Oh, well, maybe we'll give it to both of you. Go ahead. Well, no, go ahead.
We'll ask two questions at the same time, and I'll see if I can process that.
I see that there's been research done and ongoing with psilocybin for depression, and I wanted to know if you're involved with that at all, and most importantly, what the sense is at this stage between how psilocybin compares to ketamine.
Yeah. So we can't. So there is research ongoing to look at whether psilocybin has antidepressant effect. I don't think we know the answer to that yet. It is. There have been some preliminary reports, but they don't meet our standard of evidence yet to say that it's an antidepressant. There is a psilocybin study for depression ongoing in our medical center. Testing it. We don't know what the results of that study will be yet. And so we can't really compare ketamine, where we know what its antidepressant effects are, to something that we don't yet know whether it's even antidepressant yet. But I will say that I think that the path that we went through ketamine to test ketamine was one where we challenged the status quo and we're willing to rigorously, carefully evaluate a novel treatment mechanism. So I think that psilocybin is a treatment that needs the same kind of rigorous, careful evaluation, and there are this is a contentious area, so there are ways that it could go awry on both sides. One, that there are advocates who want to see it used before it's a validated treatment. I don't support that. There are people who think it's a terrible drug and should never be studied. I don't support that either. I'm more of a cautious skeptic.
Okay, last question. Yes, sir. Oh, well, I guess not. Okay. No, well, he had been waiting patiently back here. Yeah. It's nice to see this much enthusiasm this late in the program. Yes, sir.
So the studies you showed, people are taking esketamine, but they're still taking their traditional tricyclic antidepressant. Yes. So it's not so much, I don't know, it's not like you've turned this thing on its head, or it's Time Magazine, the antidepressant. You're still using these traditional methods that are related to dopamine and serotonin and norepinephrine in combination with esketamine, right?
Except I don't think that the SSRI is necessary. The only reason people are staying on the SSRIs in these studies is because it's almost impossible to get people to go off their antidepressant medications to try a new medication. It's really hard. And so the answer is there are now studies being initiated to test ketamine without the SSRIs in order to determine whether the SSRIs play any role.
So we're going to have to stop. It's really, really nice to see the kind of enthusiasm that we've got here